webinar series. Okay, this will be our last webinar for November. Just a few housekeeping announcement before we begin the session. To all participants, kindly mute your microphone and stop your video sharing or off your camera throughout the lecture or throughout the session. And for those who have questions for Dr. Yogesh later, you can actually write in the chat box or privately send the message to me. I'll pose the question to Dr. Yogesh at the end of the session later. Okay. I think because this is already 1 minute past 1, without further ado, we could start our webinar for today. Let me introduce our speaker for today, Dr. Yogeswari Sivapragasam, who is a pediatric dental specialist in Pristine Dental Empire, and she is also a senior lecturer in International Medical University Kuala Lumpur. Having graduated from University of Malaya in the year 1998, she went on to obtain her membership of the Royal College of Surgeons England in 2003, and following this, she went on to pursue her master's in clinical dentistry at the Eastman Dental Institute in London, graduating with distinction in the year 2005 and was awarded the 3M Prize Award 2005. She has been actively involved in the Malaysian Association of Pediatric Dentistry, as well as in clinical practice guideline revision group, committees for the management of severe early childhood caries and the management of condylar fracture for the Ministry of Health Malaysia. And today she will be speaking on an interesting topic on how to manage the young permanent teeth. And her topic will be, her talk for today is entitled Watching Out for the Sexy Young Permanent Teeth. So without further ado, I'll hand over the session to Dr. Yogesh. Dr. Yogesh, it's all yours now.
Okay, thank you, Dr. Rohaida. Thank you very much for the kind introduction. And I would like to also thank MAPD for inviting me to give this talk, allowing me this forum to talk on this topic. So let me get on with the lecture entitled Watching Out for the Sexy Young Permanent Teeth. So, all right, so just as we start, before we start, a little disclaimer. Yeah, the disclaimer being, when I say sexy young permanent teeth, there is no offense meant to anyone, young or old, sexy or not. And the reason why I chose the term sexy young permanent tooth is because I feel the permanent teeth are very intriguing. Yeah, so the word sexy here is actually referring to the uniqueness of the permanent teeth, which erupt at certain times in the child's life. And the other thing is that what I'm covering in this lecture is probably covered in under different areas of dentistry, but the take that we have here is on trying to see at the various points in the life of a child how we need to actually look out for these erupting permanent teeth in order that we may prevent potential problems. Yeah, so it's more of a talk on preventing issues which may potentially arise in children rather than any particular pathology or any particular problems. Yeah, so it's more of a preventive approach to things. So having said that, let's go on. So when we talk about children, we always hear this: children are not little adults. When I hear it, I always think, oh, so cliche. Yeah, we just keep saying children are not little adults. Yeah, of course, children are not little adults. They are children, aren't they? But what is it that makes children unique? Because when it comes to this permanent tooth, for instance, this is the upper first permanent molar, and this permanent molar could very well exist in the mouth of an 8-year-old just as well as it could be existing in the mouth of a 18-year-old or a 29-year-old or a 39-year-old or even a 79, 80-year-old. Of course, if we're talking about older people, then you may have some wear and little variations in the appearances will be there. But this in particular could be there in anybody, whether child or adult. It's an adult tooth. Yeah, it's an adult tooth. It could equally exist in an adult as it could in a child. But what I want to highlight is children are not little adults, but what about the adult teeth in children? Do we look at them differently because they are in children, or do we manage them the same way as we do in an adult? So the question is there anything unique at all about managing permanent teeth in children, or is there anything different that we would do when we want to handle a particular problem, or not problem, but any particular issues that may arise? Yeah. So let's take a look. See, first we have the child. Yeah. We have a spirited, growing, and developing child who is emotionally, mentally, and physically, they are constantly changing. In fact, sometimes between the morning session and the afternoon session, you can have a difference. They might be grumpy in the afternoon because it's nap time. Yeah, so they are constantly changing, and every child is unique in their own way. Yeah, and in managing them, sometimes we have to understand the whole child before we can actually deliver the treatment. Unlike an adult, because most adults have good control of their emotions, and usually when they come in, treating an adult is usually quite well, let's say, well, behaviorally a lot easier than treating a child in most instances. Yeah, but having said that, we have the parents of the children. They are a different category altogether that we probably can have another lecture on, but leave that aside. But we do have to take the parents into consideration. So when we're treating children, very often we are not only just treating the child, we've also got to manage the parents as well. Now, here we have the just a second here. All right, here we have the teeth. Yeah, so we have the child, and then we have the tooth or the teeth in the mouth. Yeah, so the first set that the child has is destined to be lost. Yeah, they are not meant to remain in the mouth forever. Now the second set, they are larger, more in number, slight variations in anatomy. There are 32 of them, yeah, that are potentially to come out, yeah. And they are meant to be there for a lifetime, yeah. So because they are meant to be there for a lifetime, then we have to think about what we need to do in terms of the long term for the child, yeah, because we don't want to affect or have a negative impact in the long-term prognosis of this child. Yeah. Okay. So here we go. So we talk about the first permanent molars first. Yeah. So they erupt around the 6th year of life, and here is an example of a first permanent molar. And as you can see, it has got in the grooves and fissures some, well, maybe staining, maybe early caries. There's some opacities just adjacent to the groove. Yeah. So what do we do with this molar? What do we do about this permanent molar? Yeah. So we have many options here. We if we think this is this is early caries, yeah, we have many options. We could possibly do a fissure sealant, or even, you know, maybe we want to do a filling. There's so many things we can do. Now I want to actually see what you would say. Yeah, so let's vote, or let's take a poll to see how you think is the best way to manage a permanent molar such as this. So maybe a minute, Dr. Faisal can share the poll, and we give everyone a minute to. Here we go. So we have the question. In your opinion, which is the best option for managing the early caries in this molar? Now, there are several options there. There's one for undecided. That's if you can't decide, but try to see what you would say. And we'll see in the end. So we have about half of our participants have answered. See, when things have actually changed quite a bit, hasn't it? From the time that the rest of us who are a bit longer in dentistry, when we were in dental school, we have, when we see a lesion like this, you know, it's straightforward. Fissure sealant, that's just early caries in the fissure, you know, fissure sealant, PRR, we just decide that way. But now, things have changed over the years, right? So, you know, I woke up one fine day in the morning to find that there is, you know, such a thing called CUMBRA, which is caries assessment by risk management, and then there is risk assessment, sorry, and then there is, you know, a different way of evaluating the level of caries. Now we do ICDAS coding, no more the way we used to diagnose caries when I was in dental school. So things are constantly changing. And so let's see, now we have 44 out of 54 who answered. Shall we? I think we will stop now. 81% have responded. Okay. Can you all, I'm not sure, does everyone see the poll, or how do we share the results of the poll? Ah, there you go. Now you can see the results of the poll. Majority, 29% have said that they would do a PRR, a preventive resin restoration. And quite a number of fissure sealant glass ionomer, fissure sealant resin, almost equal, fluoride therapy. I think OHI diet advice, something we would probably do across the board. I think everybody would agree on that. And I've said monitor rather than do nothing, because we shouldn't do nothing. We should be doing something, which is usually giving some advice on prevention, yeah? Right, and restoration is 5%. So nobody's undecided. That's fantastic. Everybody's got an answer. Okay, so thank you. We will stop sharing the results. And we will continue. So we have voted, and majority have said that they would do a PRR. Now, what entails doing a PRR in a patient? Yeah, usually if we want to get a good isolation, it should be with a rubber dam. Yeah, rubber dam isolation, or very good cotton roll isolation. This, bearing in mind, is the lower permanent molar, which, you know, we sometimes find it difficult, because the saliva can actually rise up, just as, you know, we see the floodwaters rising sometimes. So it can be quite difficult to isolate lower permanent molar, especially in a child. Yeah, so with a PRR, we really need to be very good with our isolation. All right, so let's move on. Okay, so here we have the first permanent molar erupting around the age of 6. Yeah, and so we have to think about the role of caries risk assessment in this. Yeah, so I mentioned earlier that we have this uh, issue of isolation, of understanding, sorry, isolation when we want to do the treatment, and when we want to decide on what we want to do, we really need to think about the caries risk for that patient. Yeah, so although when we just look at this tooth, we might think, okay, we will do this, we will do a fluoride therapy, for instance, or we will do PRR, for instance, the most voted for PRR. Yeah, but we we also need to have an understanding of the caries risk, because although we might do a PRR and we will solve the problem for this tooth, we have to think about the other teeth. Yeah, so there is a role in caries risk assessment in managing caries in very young children and even in adults as well. Yeah, and what caries risk assessment does for us is that when we assess the risk, and this is a talk which Dr. Rohaida covered a few weeks ago. When we assess the risk, we actually know specifically where the issues are with this patient. Yeah, so this particular patient may be, say, an 8-year-old, just new tooth, so in the mouth, oral hygiene not very good. Yeah, still having a lot of sweets and sweet snacks. It could be even an 18-year-old who is in university, and maybe now they've got a habit of constantly taking sweetened carbonated drinks, for instance. Yeah, so that could be the risk factor for them. And it could also be a 29-year-old who is somebody who's working through the night, and therefore keep snacking through the night because they want to stay awake and do their work. So caries risk assessment actually allows us to formulate a customized preventive regime, rather than us telling the patient, oh, okay, stop having sweet foods, brush at night, and use fluoride. Sometimes we just rattle on all our preventive advice generically, and that doesn't always work. So we find that, oh, why is the patient coming back still with more cavities, again with more cavities? So this is the role where caries risk assessment helps us to understand what is the patient's particular specific issues. And then this motivational interviewing is a good technique, whereby not only after understanding what the patient is facing, then the patient themselves can decide which issue they want to tackle first. Like, for instance, we may have an 8-year-old who maybe doesn't brush very well, is also having a lot of sweet snacks. But they are using fluoride toothpaste at home. So maybe then we can get the patient as well as the parent to come to an agreement. Okay, we will start brushing at night now before going to bed, and then they will maybe they can agree on how much of sugar, extrinsic or added sugars, they will have in the week. So motivational interviewing is something which is really very useful in trying to get the patient to take the driver's seat in prevention, rather than us trying to tell them what to do. They take the driver's seat. They drive the uh, preventive therapy, basically, or preventive steps. Yeah, so motivational interviewing is something for us to consider in giving preventive advice. All right, so I've so far covered the risk assessment and the preventive regime. Now we go on to delivering the intended treatment. And I've said here effective delivery of the intended treatment, because we know when we look at this permanent tooth, we know that this is likely going to be a PRR, because there is obviously some early caries on the fissures, especially here and here. We know that. Now, but the question here is, can all the permanent teeth in the various age group, yeah, be treated the same way? That's the question. Because you could have a 29-year-old who will allow you to apply a rubber dam, yeah, and you could very nicely do your caries removal, etch 20 seconds, wash 20 seconds, bond. All of that can easily take you about 3 to 5 minutes to carry out. just the procedure itself. But what if you have an 8-year-old who would barely sit in the chair, and the 8-year-old, is not going to be able to allow us even cotton roll isolation sometimes. So the question here is, the adult tooth in the child, is it the same? Yeah. So the young truly are unique, because you have the child who may not be having ideal oral hygiene habits, and if you do try to teach them, it may take them a while to get into the routine of and effectiveness of good oral hygiene. Yeah, this versus an adult, the child may take a bit longer to get onto the good habits. Yeah, and then you have their dietary habits, which may vary greatly, and it's not so easy to tell a child stop taking sugars and they will stop. Yeah, it's a habit. You're going to have to learn how to work their way around it. Yeah. And then you have the behavioral tendencies, you have the dental fear and anxiety. So that's what I was mentioning earlier. You may have the 8-year-old who may not allow us to carry out the treatment which we know how we should do, and the quality with which we need to deliver, it may not be possible in a very young child. Yeah. And then we have their fluoride use as well. Okay. And then we have the tooth itself. Now, the permanent tooth in a child, I mentioned earlier, we have the permanent tooth, which is the same tooth in an 8-year-old and in an 80-year-old. But there is a difference in these teeth, because they have just erupted. They have very large dentinal tubules. Yeah, dentinal tubules are probably around 1 to 2 microns in diameter. Yeah, that's because the peritubular dentine deposition is just taking place as the teeth is erupting in the mouth. So it happens over time. It's not immediate. So as soon as the tooth has erupted, it has got large dentinal tubules. So when you have these early caries in the pits and fissures, which are actually already sometimes into dentine, then you have caries which can progress very quickly. I actually looked up before this lecture what's the size of the strap mutans. A strap mutans is only about 0.3 microns in width. So if you think about it, a 0.3 micron bacteria, it can actually, go down the dentinal. They can march hand in hand through the dentinal tubules right down to the pulp if they wish to, because it's so huge. Yeah, the dentinal tubules are so huge in comparison to the bacteria which are in the oral cavity. So that is actually a significant factor in treating these children, because we want to get to them quickly so that the bacteria doesn't get down to the pulp too quickly. Yeah, so that's one aspect of it. The other thing is, in a child, the pulp chambers are bigger, and they do tend to have high pulp horns because the tooth has just erupted. Again, secondary dentine deposition hasn't taken place or is slowly being deposited. So it will take a few years before the pulp chamber comes to a smaller size. So again, the pulp chamber is very close to the area where the caries is taking place in the enamel surface, and then the early dentine caries. So again, we need to give them a very quick and definitive kind of a response to this caries in order to make sure that it doesn't progress quickly into the pulp chamber, which is basically where more problems start, because then the patient starts to have symptoms, and usually with pain there is increased anxiety in children as well. Yeah, and there's the issue of post-eruptive maturation, because when the tooth erupts, we know that it's not it absorbs more minerals after its eruption. So you get fluoride being absorbed and other minerals hardening the enamel surface. So initially, as the tooth is erupting through the gums, when it's just below the occlusal plane, and exactly when it's below the occlusal plane, more difficult to brush, more plaque deposits, is when it's at risk. Yeah. So these molars are actually unique, and they do need to be treated slightly differently, especially when we want to take into consideration the health of the primary teeth, because we do know that when primary teeth are carious, then the first permanent molars are very likely to be at greater risk for getting caries. So this is where we can give some anticipatory and preventive advice to our patients, that when we see primary teeth which are carious, we're seeing them for caries in primary teeth, we can actually let them know all these things have to be modified So when the permanent teeth come out at 6, they are not as susceptible to caries. Yeah. So let's look at this molar again. So we said we will do a PRR. Mostly have said they will do a PRR. So we can imagine taking a little drill of making a hole here, and then we've got to do an etching, dry it and wash it and dry it and keep it dry while we bond and apply the restoration. Now, that may not be so easy if the child is not cooperative. And what more if it happens in a tooth where the tooth is just erupting, so the gum margins are not the tooth is not really through the gum margins yet. So here you have a scenario, even if you have a cooperative child who will allow isolation, if we were to try to do a PRR, or even fissure sealant for that matter, we will have seepage of the gingival clavicular fluids. Yeah. So very likely what will happen is when we have done a beautiful fissure sealant like this, after some time it will break, it will dislodge or give way in this area. Yeah, just where we got the contamination. Initially it will look good, but it will start to break down very quickly. Now, here is where the danger lies, because we have, say for example, we have a child who is very high caries risk, and we have a fissure sealant that has failed because of the moisture control. Then we have actually provided the bacteria sort of a protected area now. Yeah, because you have part failure of a fissure sealant, you may have food or plaque traps in this area. I wish I could have got a photograph, but I couldn't. But you could actually have a plaque trap created where the rest of the fissures are sealed, and you have a small area which is now given way. And we see the patient in another 6 months. Sometimes they don't come back, and what you end up having possibly is caries progressing underneath the, just underneath the surface. And we are not any the better unless we take x-rays or we can see the shadow of the caries progression. So basically, the caries risk assessment will tell us whether this child is at risk for getting further decay, and the effective prevention will actually help us to reduce that risk. And child behavior management is of paramount importance in ensuring that we actually deliver the intended treatment in the right way. So before I carry on, let me go back to this slide, and referring back to the question that we had on the poll. We may, if the child has a very high caries risk, we may then decide, instead of putting on trying to do a PRR where we will actually have to make a hole and then we'll have to isolate and make sure we get a good restoration in, we may just decide to do a GIC based fissure sealant instead. Yeah, and the advantage of that would be that even if it does give way in certain areas, the rest of the GIC is still there leaching fluoride. Yeah, and we hope that would help to arrest the caries in progression. So that's one option. Yeah, the other option is not to even do fluoride, GIC based resin fissure sealant. Sorry, GIC based fissure sealant. Rather just apply some fluoride. Yeah, in fact, now we have SDF, and that's one of our next talks coming up in next month. In the coming month is on SDF, and I might actually just apply some FDF here and see if we can just get the caries to arrest while the patient is getting the oral hygiene and the prevention going on. Yeah, because that will take time. So we can maybe get some fluoride on board, possibly fluoride and GIC as well. Yeah, that is SDF, and then cover it with some GIC. So these are all options to consider if the patient is not going to cooperate. Like in this one is quite clear cut because the gums are still there, it's not fully erupted, so definitely not indicated for a resin based treatment. But in this slide, the first one, it is a possibility to do a PRR, but we do have to consider the child. If the child will allow us to isolate well enough for us to deliver a good restoration. Yeah, if not, then we probably have to fall back on something which is more temporary and emphasize on prevention, so that we don't get very quick progression of the cavity and caries. Yeah, so that brings me now to deep caries. Yeah, so sometimes it does happen that the straps and the bacteria march down those big, huge dentinal tubules, and they reach the pulp really quickly. Yeah, and we sometimes have deep caries in a young child, in a young tooth, which where the roots are even not fully developed yet. Yeah, so this is a slide, or I'm sorry, this is a X-ray radiograph PA of intraoral perioptical radiograph of the molar, of the first permanent molar, with deep cavities. You can see right down to the pulp. Yeah, it has actually gone past where the pulp horn would be. We would expect the pulp horn to be somewhere here. Yeah, so it has actually gone past into the pulp. Yeah, this patient actually presented with uh, signs of reversible pulpitis. Yeah, and he came because he was advised to have a root treatment done. Yeah, this patient was advised to have root treatment done, and this is what we would normally do. We would do a root treatment when there is deep caries. I remember when we were in when I was in dental school. I mean, nowadays in dental schools, for the clinical aspect, we have simulated patients. But in my time, we used to have real patients, and we had to bring in a patient with deep caries, or sort of moderate to deep caries, to treat on the exam day, there and then in the clinic. And my patient happened to be something similar to this, yeah, where when I removed all the caries, what had happened was, of course, naturally the pulp was exposed. You know, we remove all the, we make sure we get all the caries out of the walls, and then when we get to the floor, and naturally pulp exposed, so that means it had to become a root treatment. I had to extirpate the pulp, and that means root canal. I had to start root canal therapy on my exam case. So this is something which we, as students, we were told, no, try not to do root canal treatment because it's very complicated, and of course that can affect our results, and etc., etc. But having said that, nowadays we don't have that kind of exams anymore. It's all simulated patients, so variability for the students are handled. But in terms of the patient, now, at that time, that was the recommendation, that when you cariously expose a pulp, especially if it's a large exposure, then we proceed to do a pulpectomy and a root treatment. But things are slowly now evolving. Yeah, just as we were talking about the PRR, and how we didn't used to have ICIDAS coding and Cambra and all those things, but we have it now. And now, even for deep caries, things have changed. We are now moving towards minimally invasive, more biologically based treatment. So although at one look, this molar would look like something we would start root treatment on, and bearing in mind, starting a root treatment on a child who is 8, 9, 10, 11, 12 years old, we are putting the patient into the restorative cycle, very far down the restorative cycle really quickly. Yeah, so that would mean shortening the life of this tooth, which we hope would actually last towards to the end of the life of any individual. So nowadays we are moving towards minimally invasive, biologically based treatment. And here I showed you, I'm presenting the European Society of Endodontology's position statement on management of deep caries. This was published on January last year. In January last year. There is a Cochrane review, which when I went to look for it, it has been taken down because it's being reviewed. So there is no current Cochrane review. The last Cochrane review was in 2013. We prefer to rely on Cochrane reviews because that's sort of higher level. But anyways, we have the European Society of Endodontology's position statement on how we manage deep caries. Firstly, we want to avoid a pulp exposure. Yeah. So like the radiograph I showed you just now, pretty clear that it's already in the pulp, so may not be able to avoid. But we'll talk about avoiding pulp exposure. So basically, we do a selective caries tissue removal, whereby we remove the caries tissue from the walls, try to save the caries, the affected dentine on the cavity floor. Yeah, so we want to preserve that part and not expose the pulp. Yeah, so non-selective caries removal is no longer regarded as the treatment of choice in deep caries now. So what I had done for my exam case in all those years ago was right at that time. Yeah, that was what was done at that time, but it no longer is accepted. Yeah, so right now we ought to be trying to avoid exposing the pulp whenever possible, but sometimes it is not possible. Yeah, because the patients are having symptoms. Yeah, they sometimes have symptoms of reversible pulpitis or even irreversible pulpitis. Yeah, so then we want to manage the carious pulp exposure. In those days we used to, if it's of a certain say, we used to say if it's a pinpoint exposure, then we put direct pulp capping with dical and restore it. But now we don't, when we expose the pulp, we have materials which are bioactive, which actually can help and promote healing of the pulp. So if we recall how calcium hydroxide works, we always have used dical or calcium hydroxide to line pulp, and calcium hydroxide is very alkaline. Yeah, and histologically it has been shown that it causes inflammation within the pulp chamber, and that is how the secondary dentin is deposited, because of the irritation to the pulp. Yeah, so that's the mechanism of how calcium hydroxide works. But with the current materials we have, which are bioactive materials, they promote healing rather than create further inflammation. So what happens is we can actually preserve the pulp. Yeah. So here, the recent studies have confirmed high levels of success. Yes, it says here several recent studies have confirmed high levels of success after non-selective or complete caries removal. Yeah, which we then know we're going to deliberately expose the pulp, as it is in this case. You can see how much of the pulp has been exposed when the whole lot of the caries has been removed. Yeah, and what you get is then you can do a enhanced VPT, is vital pulp therapy procedure. Yeah, involving the use of calcium silicate cement, and it says here specifically in the position statement, not calcium hydroxide, because of the reasons I explained earlier. So we want to use either biodentine or MTA. We can line this area, yeah, and then restore it. Another option is actually to do a full pulpotomy. This is just a selective pulpotomy just in the area where the caries was. So after exposing the pulp, we actually have to take a high-speed diamond, sterile diamond burr, and actually amputate or remove 1 to 2, 3 mm of the pulp. Yeah, just as we do in the cases of trauma. So we just remove that amount of pulp, wait for the bleeding to stop, and it will stop when it's reversible pulpitis and the pulp is not hyperemic. It will stop on its own without any intervention required. Yeah, and then just some gentle irrigation with saline, sterile saline. Yeah, all this done under rubber dam, of course, and then we can proceed to place the bioactive material. Examples of it is MTA biodentine, and then completely cover the tooth. Yeah, that's one way of doing it. The other way of doing it when we have such a big exposure is to actually do a cervical pulpotomy. That means remove the entire pulp from the pulp chamber, leaving only the pulp at the root stumps. And then we can fill it up with the bioactive materials and a restoration as well. In this particular patient, I decided not to do the cervical pulpotomy because I realized that quite a bit of the dental tissues are quite healthy. Yeah, so I will actually have to remove all of this to access the pulp chamber. So it was decided to just do it this way. Yeah, so this is something that we can consider, yeah, in the child patient. Even in adults as well, now we're doing this because we can actually push the patient from having to go down the restorative cycle, further down the restorative cycle by starting root canal treatment, right? So this is an example of how we can manage this deep caries. And of importance is the seal. I would say the deal is actually in the seal, because if we fail to seal this cavity properly and we get micro leakages, then this pulp is subject to the onslaught of the bacteria straight away. There's no saving it. After that, they're most likely going to become non-vital. Yeah. So very good isolation. Yeah. So there no contamination of the cavity. Yeah. We want good isolation under rubber dam and a good coronal seal. Yeah. Would help to improve and maintain good prognosis for this tooth. Yeah. And we want an appropriate selection of material and using a good restorative technique. Yeah. Whether we want to use composites or amalgam. Now, why I mentioned restorative technique is very often these cavities are not so straightforward because they are proximal to surface cavities. Yeah. Where the proximal is likely to be either at the gum level or below the gum margin. And under those circumstances, if we don't choose the right technique, then we don't get the seal. Yeah. And if we don't get the seal, then it fails. Yeah. And we end up with a root treatment. So it's always the seal. Yeah. We should be able to make sure that whatever we do, we maintain good isolation, it doesn't get contaminated. And if we provide a good seal with the bioactive materials that we have now, we actually can get good prognosis, and we end up with, in cases of where it's immature, where the roots of the molar is immature, you actually get continued root development. Yeah, it continues to develop normally. And if later on, if it should happen that the tooth becomes non-vital, definitely endodontics in a completely formed root is easier than trying to do endodontics in a open apex situation. Yeah. And here I'm also mentioned behavior management, because all this advanced treatment or more, treatment which is a little bit more complicated with more steps, sometimes it's not possible if we cannot manage the behavior of the child. So managing the child's behavior is equally important in achieving a good prognosis. We must be able to handle the anxiety that some children may have, and if needed, we may have to use some advanced behavior management techniques as well, in order to be able to deliver the gold standard, meaning a good restoration for the patient. Yeah? Okay, so here we have another situation where the permanent tooth is erupting around the age of 6, 7, and you can see that it's got a slightly different color to it. Yeah, and this is molar incisor hypomineralization, and this is a topic which will be covered in our series of webinars down the road in next month, in the coming month. So I won't go into too much details, but I just want to, for the purpose of this lecture, apart from caries, highlight what are the other issues that could come up in the developing dentition. And this is very something we are seeing more commonly. I'm not sure whether it's because we are more alert to it now, but this is what we are seeing now. Yeah, and this is a patient of mine whom I actually noticed when the incisors erupted, the lower incisors erupted, that he's likely to have MIH. And true enough, I put him on a recall, which is a closer recall period, and managed to catch this molar erupting. Yeah. So, and then I see him again in 2 months. This was under 2 months, and that much of breakdown has taken place. Yeah. And GIC placed on this surface was of no help, because you can see the enamel has come off from the dentine with whatever protective restoration that was on the tooth. Yeah. And these are his lower molars came up like that when I first took the picture. And if you notice the ease, yeah, this is a telltale sign. Sometimes when a child is, some studies have actually shown that MIH is most often preceded by some hypermineralization on the ease, yeah, on the primary ease, on the second primary decidus molars. Yeah, so this is a telltale sign. So if we sometimes see patients who have got cavities on the distal of an E, we must start thinking, Why is there a cavity on the distal of the E when there is nothing at the back? There's no other teeth at the back. This is when they're younger, yeah? So we do need to keep an eye out and maybe give some anticipatory preventive advice to the patients and the parents, mostly the parents, that they do need to come for regular checks so we can pick this up early before it gets into deep caries, yeah? All right, so we have this molar, which 2 months later was like this. Yeah. So again, it still hasn't come through to the occlusion yet. It's still beneath the gums at the distal. Yeah. And that much of tooth surface loss has taken place already. So very rapid post-eruptive breakdown happens in some cases of MIH. And really nothing much we can do, because if it has fully erupted, we can then put a stainless steel crown, protect the tooth. But in this case, literally it was breaking down under my nose. Yeah. So an OPG, and you can see the 1/6 and the 4/6, there are just no enamel. Yeah. Whereas on the same patient, the 2/6, yeah, the same patient, the 1/6 and the 4/6, you can see enamel. Yeah. So I didn't put up the photographs of the other two molars, but they are not as bad. Yeah, just a few spots and restorable. Yeah. But you can see the enamel on the 6s are there. Yeah. So this patient, I referred to the orthodontist for a second opinion as well, because looks like this 1/6 and the 4/6 don't have very good long-term prognosis. But this patient doesn't look like he needs any braces. He's quite likely to have a very well aligned jaw with class 1 molars. And so the parents are now deciding, because this is the right time to extract the molars, the first molars, to allow the second permanent molars to come through and take its position. And the timing is when we have calcification at the furcation area of the lower molars and the upper molars. Yeah. So the upper molars, we can delay the timing a little bit. They still do erupt into the space quite nicely, but not so much the lower molars. Yeah. So sometimes we have to think about that. Yeah. All right. So looks like I'm up in time. So this is another case, similar situation. And the other thing we need to look out for on erupting teeth is the incisors. Yeah. So the incisors, you can have either deep bites. Yeah. If you can see this one, the bite is exactly at the gingival margin, potentially can cause periodontal problems. So we do need to look out for things like this, pick it up and refer the patient appropriately for early intervention. Yeah. Because they would need interceptive orthodontics. Same thing goes for here. We've got a cross bite, and sometimes we get gingival stripping or loosening or mobility in this incisor, yeah, because of the chroma of the crossbite from the upper incisor, which has erupted lingual to the lower incisor. Yeah. Another scenario we may have is this. This is a case which presented with an abscess on this lateral incisor. I couldn't really see the restoration initially, but after some etching, this is a little trick. Yeah, just etch the enamel, you can see. So a dentist has actually placed a restoration, may have had a deep fissure in this tooth or deep pit in this tooth. And then, but anyways, the patient came with an abscess related to this tooth. But interestingly, if you can see, the central incisor has a deep groove as well. And on the radiographs, which we took for the laterals, we can see that it's got a nice fissure going right into the pulp chamber. So this needs a fissure sealant. So really we need to do some preventive therapy on this patient by providing fissure sealants could help prevent the need for root treatment in the long term. Yeah. Now here we have a patient whose primary incisor, the 4-1 has erupted, and the 8-1 is not exfoliated. Again, if this carries on to erupt, we want to remove the central incisor, the primary incisor, to allow the permanent incisor to drift into its space. This patient came in a little bit late at 10 years of age, yeah, and already lost some space, yeah. And you can see that the incisor is up here, yeah. So these are things which we can pick up on regular checkups, and if picked up early, we can prevent the need for more extensive treatment, yeah. This is a protrusive incisor. So again, some interceptive orthodontics can be done. It's a choice. And if not, then we need to protect these incisors because they are at risk for trauma. And we can advise the patients to use mouth guards, yeah, if they are active in sports. But then again, these incisors are still at risk at other times, because it's not only when child plays sports. Yeah, the child could very well have an accident another time when they're at home. So this is really something we need to look into as well early on when the teeth erupts. Yeah? And then we have trauma, incisal trauma. If it's just the enamel, it's easily either smoothened. If it's dentine, it needs a restoration, because if you remember, in erupting teeth, the dentinal tubules are very wide, and the bacteria can actually travel down to the pulp very quickly. Yeah. And so again, if it's involving the pulp, we can use bioactive materials like biodentine or MTA, and do a vital pulpotomy to allow continued root development. This is an example of a case which had a crown root fracture. So actually a very deep pulpotomy was carried out to cover the area of the fracture. Really, this case was considered to be poor prognosis, but eventually it did survive. Yeah, as you can see, it continued to have, from being open apex, continued to have root growth. Yeah, this is a CBCT, and this is the restoration. Yeah, so a good seal is important, because without the seal, this will leak. In fact, this patient did have a problem because this fracture didn't heal. Yeah, and there was an infection. Later on, many years later, there was a problem with this. But ultimately, the root had continued to develop. So when it came to a root treatment later on, it was easier to handle. Right, so now we come to the premolars. So what happens with premolars? Oftentimes we get this densi vaginatus or Leong's premolar, right? And this inevitably fractures when it comes into occlusion and can result in the loss of vitality in an immature premolar. Now, that is something which complicates root canal treatment. So one of the things we can do is to gradually shave off this tubercle to stimulate secondary dentine deposition within the pulp chamber and the pulp horn, which is likely to be within this tubercle. Yeah? So this can be done, the gradual shaving can be done if it's in this stage where it's just erupting. But once it comes into occlusion, and if we see the patient when this is getting into occlusion, then maybe the best thing to be done would be to actually just remove the tubercle, yeah, i.e. just amputate it there, and then seal off the pulp that is exposed using biologically inert material. The success rate of pulpotomies are so high that it is worth doing this. And when we know that inevitably, when it comes into occlusion, it's going to shear off when the tooth is not fully grown yet, not fully matured yet. So this is an example where the tooth has become non-vital, and and what we have to do here would be apexification, where we probably can use some MTA and do a root filling. Yeah. But now we also have regenerative endodontics, whereby we can hope to get some apexogenesis as well. So regenerative endodontics is something we need to keep in the back of our mind. It's a possibility for something like this. Yeah. And this is a PA of a tooth with a tubercle, yeah, where we can probably do a vital pulpotomy. You can see the pulp chamber going right up there. Yeah. Right, so that pretty much covers the few things which I could think of. It is not by any measures an exhaustive list of things that can occur in permanent teeth as they are developing, but they are to some extent a certain number of possibilities that some of the possibilities which can occur. So just sharing all the my experience, as well as the what is current in managing these teeth. And so with that, I end my talk, and I also would like to introduce or mention the next speaker, who is Dr. Yo, who's going to be talking about SDF. And I'm looking forward to this as well, because I mentioned earlier, I'm also just started using SDF, especially on early caries, future caries, to see it kind of helps us to do less and very useful when we are dealing with a child who is uncooperative, and we may end up having to do a general anesthetic. So this really helps quite a bit. So looking forward to this talk coming up on the 9th of December, yeah, next couple of weeks time. And with that, I thank you all for your attention, and I welcome any questions.
Okay, thank you very much, Dr. Yogesh, for a very enlightening, and it's a very good recap, revisit to how to manage the young permanent teeth. Okay, as Dr. Yogesh has mentioned earlier, she's ready and to receive questions, and if we ran out of time for her to answer that, you can still post the questions in the chat box, and we will do our best to answer and post it in the social media later. Okay, any questions? Okay, I guess, oh yes, there's one question. Okay, Dr. I guess we do have one question here. How, this is from Eunice. How do we determine whether to wait, if wait, and how long do we wait, or to extract the primary incisors? And this is because parents concerned about crowding, but isn't crowding caused by the lack of space? So the question is, how do we determine whether to wait? And if we were to wait, how long do we wait?
Okay, thank you, Audrey, for that question. That's a good question, actually, because we oftentimes don't know when to extract the tooth, because we cannot really go by age, because every child develops at a different stage. So basically, it's to look at the general development of the teeth in the oral cavity. Like, for example, if you have the four lower central incisors erupted, and you find that the upper central incisor is not come through yet, the child might be, at the age of about 8 or so, whereby you think, no, this is time for the central incisor to come through, but it's not coming through. In fact, it's bordering on the time where the lateral incisor might be coming through as well. So you have to go by the sequence of the eruption of the teeth, yeah, whether the eruption pattern is following the sequence, or whether the next teeth on the sequence is showing signs of coming through, and this particular tooth still hasn't exfoliated yet. Yeah, so then you will actually need to remove that primary tooth to allow the permanent tooth to come through. If you don't even see signs of the permanent tooth and the primary tooth is retained, and you're looking at the sequence of eruptions, the child is going towards missing that time frame for that tooth, then that would mean that you may have to take an X-ray, a radiograph, to actually see whether the permanent replacement is present, and whether if it's missing, and what you need to do after that will depend on what you find on the radiograph. So it is always depending on the eruption sequence. Yeah, if you're passing the time frame, then you do need to remove the primary tooth, to allow the permanent tooth to take its position.
All right. Okay, thank you, Dr. Yogesh, for a very thorough explanation on that. There's another question from Najwa. Doctor, do you give LA when shaving down the tubercles on the teeth?
Usually I don't give LA. The reason being, if the patient is showing sensitivity, I want to know about it. Yeah, because if not, you could very easily go too close to the nerve. Yeah, and then by shaving the tubercle, we could actually be causing a problem. So I don't give LA. You only need to remove very minute amounts, yeah, 1 millimeter or less each time. So it means the patient has to come often to see you. The alternative you can give the parent is to just remove the tubercle and do a pulpotomy. In that situation, definitely you need to give a local anesthetic. But in shaving, I don't normally give any LA because I want to know if the patient's sensitive, and if they are, I stop. Yeah, I stop. That's the indication to not continue anymore. Allow time for secondary dentin deposition and manage the sensitivity as well. Yeah, I hope that answers the question.
All right, thank you. Thank you again. Well, I guess it's already 2 o'clock and we've come to the end of the webinar, but okay, I guess we can allow for one more question. Just to answer Eunice. Okay, that's another question. Assuming the permanent tooth is already partially erupted on the lingual side and there is, for example, mobility of the primary incisor, would extracting the mobile lower incisor help in preventing the potential for crowding?
If the primary incisor is already mobile, I think you're saying mobility. There's mobility, right, on the primary incisor. If the primary incisor is already mobile, and if it's really very mobile, then really not necessary to extract because it is going to be falling off soon. It's only when it's either moderately mobile or fairly firm that we want to remove the primary tooth to allow the permanent tooth to come through in the right position. If it's mobile, what I normally do is I tell the patient, no, go home, keep pushing on that tooth, play with it, get it to come out on its own. So that's what I normally advise if it's already mobile. I try my level best not to put the child through an extraction when it can be avoided, simply for behavioral reasons. You sometimes will have a very cooperative child, and just because we try to do an extraction and they've experienced some pain, they may then turn into uncooperative patients because of anxiety and fear from the pain. So we normally gauge by the actual need as to the timing on how high or how much the permanent tooth has erupted, whether it's almost fully erupted, or if it's only just little way through the gums, then we have time to wait. But if it's almost fully erupted, then yes, maybe you would consider taking out the primary tooth if it's still firm. That is, yeah.
Okay, I think that pretty much sums up everything for today. But fret not, if you still have some question for Dr. Yogis to answer, you can actually post it on our Facebook page, our Instagram, and I'm sure Dr. Yogis doesn't mind answering that.
No,
The
certainly
question.
not. Yeah, I will
Okay.
yes.
All right. Do tune in for our next webinar, which is on the 9th of December. There'll be something interesting to hear. Okay, to all, thank you again for being here with us. Have a fruitful day and have a nice day. Thank you.
All right, thank you.
Oh, don't forget to sign into the link given for your CPD and certificates. All right.
Thank you.